Hi, I'm Dr. Rebecca Walker, and today we'll continue with part 3 of the shortness of breath case. We started with a 52-year-old female. She had been wheezing for 2 days and having trouble breathing. She came to the emergency department hypoxic. She was speaking, but she started becoming more somnolent. Her past medical history, she had some breathing problems in the past. She had been exposed to dust recently when she was cleaning her house, and we positioned her in an upright position and started her on some oxygen by face mask. We also put her on a continuous pulse oximetry. We took a history and found out that she had a recent exposure to dust from sweeping her house. She had these similar symptoms that previously, and on her physical exam, she had bilateral wheezing in her lungs. She showed accessory muscle use in her neck and in her chest wall. She had no signs of fluid overload or edema. So we take a more detailed history now that she's a little bit more stable, and find out that no, she hasn't been having any fevers. She has been having a little bit of cough, no chest pain, no tarry or bloody stools, no vomiting, no weight loss, no hemoptysis. She does have this prior history of similar symptoms. She denies being a smoker. She denies having palpitations or syncope. And these are all very important questions to ask any patient who comes in with shortness of breath. So when we find out that these few things kind of come to our attention, we want to take a little bit closer look on what those mean. So our patient says, yes, she has had these similar breathing problems in the past. We ask her if she had wheezing before and if her symptoms seem very similar to what she has today. She also tells us that she has indeed needed nebulizers and steroids to treat her problem in the past. So we remember the long differential diagnosis of shortness of breath, and we really are narrowing it down now to that she likely has the diagnosis of asthma. And so when we find out more about what asthma is exactly, we look at the airways, and this is the bronchus, and we see here the smooth muscle dilation which narrows the bronchial tubes. You also have bronchoconstriction that narrows the airway. So the problem is that there's not enough space for the air to actually pass through these air passages. Here we see an increase in mucus production, which is also a problem with asthmatics. Often the mucus has to be cleared by coughing, so that's why coughing is often associated with an asthma exacerbation. So thinking about what we saw in the video, we see here that an asthmatic bronchiole has a much narrower passage for the air to go through than a normal bronchiole. The air goes faster, and that's what causes the sound, the high-pitched sound of wheezing that we heard earlier in our patient. And two of the mainstays of treatment for asthma and asthma exacerbation are steroids and nebulizers, so what we call beta-2 agonists, which help to dilate the smooth muscle and open the patient's airway. Steroids take a little longer to work than the nebulizers. The nebulizers actually work within minutes. So when we mention steroids, prednisone is a good choice, 60 milligrams PO dose for adults. If the patient is unable to tolerate PO medications, we can give IV methylprednisolone or solumedrol, 125 milligrams. And this again suppresses the inflammation that we saw earlier in the airway. Beta-2 agonists, albuterol, salbutamol, this causes the smooth muscle to relax and just dilates the bronchial passages that we saw there. 2.5 to 5 milligrams every 20 minutes, and you can give repeated doses. In fact, if the patient has a very severe exacerbation of asthma, we should consider just starting them on a continuous neb for asthma exacerbation when they come to the emergency department. In the crashing asthmatic, so someone that you're really worried about and almost, someone who looks like they need to be intubated, we really want to try to avoid intubation if at all possible. And so we would give that patient 2 grams of magnesium IV and also consider subcutaneous or IV terbutaline or an epinephrine, terbutaline drip or an epinephrine drip. Patients can have allergic triggers that might start an asthma exacerbation. Sometimes it's an allergy or exposure to dust, as in our patient. Cigarette smoke or a viral infection of the lung or chest can also trigger an asthma exacerbation. Pollen or other environmental allergens, as well as animal fur, can trigger an asthma exacerbation. Our patient had been sweeping her house and was exposed to dust. So this is a common reason that someone has an asthma exacerbation, is that it was a trigger from something else. High-risk asthma patients are important to identify. So if the patient that you are seeing in the ER is at high risk, meaning that they have previously had asthma that was uncontrolled as an outpatient. Maybe they're increasing the usage of an albuterol inhaler. If they've been intubated or hospitalized in the past, if they have worsening symptoms. These are important things to identify in the patient that you're seeing in the emergency department, because this is someone that you might consider admitting to the hospital versus sending home, given that they're high risk for deterioration later. Diagnostic testing in asthma is often not actually necessary. If you are considering another diagnosis, then it's a good idea to get an EKG for any heart problems. An Xray, a chest Xray, is also not generally needed just for an asthma exacerbation. If you did get a chest Xray in an asthma patient, it would likely look like this one, which is hyperinflated. We see here the full lung fields, and some of that is due to air trapping and difficulty in the patient exhaling all the air that's being trapped in their alveoli. So lab tests are also something that actually have a pretty limited use in asthma, but if you are considering a patient with shortness of breath and you're not sure of the diagnosis, then they can be useful. We would get cardiac markers if we think that there's a chance for any cardiac cause or ischemia. Electrolytes can show if the patient has an anion gap or acidosis or dehydration or other electrolyte abnormalities. Leukocytosis can point towards a possible infection, and hemoglobin can give you the answer if the patient is very anemic, and that's the cause for the shortness of breath. In asthma, none of these laboratory examples are totally necessary, but they can be helpful in ruling out other things. So let's take a look at our patient. And we see here that her oxygen saturation has very much improved. It's 97%. She's sitting up and she's looking a lot more comfortable. However, she's still on a face mask oxygen and requiring that oxygen to maintain her saturation at 97%. So this is a patient that definitely needs to come into the hospital and have continued oxygen supplementation and reassessments, because she is at high risk for doing worse at home, given that she's requiring oxygen in the ER. So in summary, we want to give every patient with asthma some key interventions that can really be life-saving. Asthma is a very common condition and a frequent reason for patients to present to the emergency department with shortness of breath. So we want to treat every acute asthma exacerbation with albuterol, beta-2 agonist, and steroids to decrease inflammation. If the patient has very severe asthma, we really want to try and avoid intubation if possible. And so we would consider giving magnesium, 2 grams IV, as well as a terbutaline epinephrine, either subcutaneously or a drip. And we want to consider admitting to the hospital any high-risk asthma patients. So patients who have been previously hospitalized or intubated, and as well patients who are requiring oxygen, of course, in the ER. So they can't have oxygen at home, most of them, so this is someone who would automatically be put in the high-risk category. Thank you so much for your attention, and this concludes the shortness of breath case. Thanks.